ophthalmology in India at Guru Nanak Eye Center, and this is going back 93. After I completed my eye training here, I moved to UK, and I went back into the training ladder there, and now I'm at a position where I find myself and meeting this group. I'm really excited, I have to say. It's, I think, the best thing that's happened in this trip, because we came to India just New Year's, and I was telling my wife that I need to go back in 3 weeks' time, and she said, like, no, you haven't gone to India for 2 years, and now you're making another trip in 2 weeks. Like, no. So I think I'm really excited meeting everyone, Dr. Gyan Prakash, Professor Ivata, and like my colleagues who are leading the fort here in India, Dr. Kumar, Dr. Shubho. So it's really exciting time. But what I want to share with you is few things. My background in terms of genetics, and now I have actually in more fields as a consultant. My area of expertise is slightly different. However, I think there's a lot of scope, and it's as Dr. Kumar said, like, it's the link between the scientists and clinicians which need to happen, and that's the way we can move forward for the benefit of our patients. So what I'll do is I'll just give you a bit of background about foveal hyperplasia, which I was looking forward to see Dr. Kumar, because I worked with Chris Engelhorn when I was doing my lab work. So I took time off my clinical commitments and did some lab work in Leeds. And the background to this actually foveal hyperplasia, it started, which was part of my initial research project. So I want to, without going too much into the details, I want to talk about this family, how it came about. So I was working in ophthalmology in Leeds, and I basically came in contact with Chris Engelhorn, and I expressed interest. I wanted to do some research, and he said there's this interesting family in Leeds, Bradford, and do you want to work on that? So as a clinician, it was a completely new area, and lab work was, like, completely alien to me. What excites me is like, interaction with patients. So it was really challenging those 3 years. But this family was really interesting. So I had to go to Bradford, and the interesting thing was I had to examine the patients at their home, which is very unusual. Normally you would expect patients to come to the clinics, but in Leeds, Bradford, we are in a unique position there, because all the families are highly consanguineous, which offers, in terms of genetics, a good opportunity to find out the candidate genes. So this family, when we started, the patient, all the affected patients, they had poor vision. And the cause of the poor vision was, from clinicians' point of view, foveal hyperplasia. And when I went and, before I actually started work on this family, so I applied for a grant, because science only moves if you have money, because all the techniques which you use in the lab, exome sequencing, all this is like, you need money, and for money you need application grants and all that. So I got a grant from Wellcome Trust to work in lab, and this was the family I started my work on, and I was really excited because I thought we had a new candidate gene, and that would be my fruitful 3 years if I find a candidate gene. But as all of you know who work in lab, things can just, like, 3 years can become many years, and you won't still find a gene. It's like looking in a haystack. So my predecessor clinician, he looked into this family, and he did some basic work, and he excluded PAC6, which was one of the genes for foveal hyperplasia. From clinician point of view, this family, they had these 3 sepships, and you can see, like, they all had married first cousins, And all the affected patients in this pedigree, what I found is they also had some anterior segment dysgenesis. So I call this clinical phenotype as a combination of anterior segment dysgenesis with foveal hyperplasia. And we started looking into candidate genes which are like transcription factors, which affects the pathways which affect the which causes problem in the front and the back of the eye. So as I think Kumar showed his family, so this is the family from Leeds Bradford we started the work on, and they didn't have you couldn't identify the fovea very clearly. So you can see like the vessels going close to the fovea, which is one of the things you see clinically. And doing an OCT is a nightmare on these patients, but with the new eye tracking OCTs, all the spectralis, you can get lovely pictures. So this was one of the basic OCTs, the Zeiss one, which we managed, and there was no foveal pit. And this is the other bit which excited me is all these patients, they had anti-segment dysgenesis. However, the form of anti-segment dysgenesis they had was the posterior embryotoxon, which is there in about 5 to 10% of the general population. So we were thinking whether it's actually the phenotype has some connection with the front bit of the eye, or it's just like a red herring. So anyways, what I did was I examined the family, and all of them had some form of anti-segment dysgenesis. So they all had posterior embryotoxon, and 2 of the affected siblings had Axenfeld. They had adhesion. So we thought they had some form of more advanced anti-segment dysgenesis. But the other thing was we from clinically examining these patients, foveal hyperplasia, what is the other common condition? So aniridia was not there because they didn't have any eye problems. So the other thing was albinism. And we looked into their childhood photographs because I was told some of the times the children, they lack pigment when they are born, and they kind of can be missed when they are adults because they acquire pigmentation down the line. So we were convinced these patients, they don't have albinism, they don't have aniridia, so what do they have? And that was my initial work I did in the lab, and did some linkage work and found a locus which was on chromosome 16q, which I published. And that's where I kind of ran out of, because it was still quite a large region, and it had about more than 70 candidate genes. So what at that point, that was 1 year down the line into my research, I decided, and me and Chris said no, do we carry on looking for candidate genes and finish your 3 years of research, or shall we jump? And then the remaining bit of the work I did was with him on some LCA families. So then I went back to my clinical work, and I moved down to London, to Moorfields, and started my fellowship there. When I was doing my fellowship, I saw this publication from the Dutch group, Van Geneden, and she published this chiasmal misrouting and foveal hyperplasia without albinism. And I thought, this is my family. So what they had done is they had not done any genetics work. So I wrote back to Chris that we need to do VPs on our family, because maybe our family, they have chiasmal misrouting. And all this, couple of the patients in my family, they had electrodiagnostics, but it was very preliminary electrodiagnostics which was done in Sheffield, which was still developing as a lab. And the patients, when they went for electrodiagnostics, they were very young, so the results were not very accurate. So I sent a couple of the patients down, and they actually had chiasmal misrouting. So what happened there is we collaborated with the Dutch group, and we got their samples, and then Chris analyzed, and basically they segregated to the same locus. So we then thought, from clinician point of view, is these are the 2 possibilities. So this is a new phenotype, and they named it foveal hyperplasia optic foveal hyperplasia and optic decussation, this combination. And The other thing which I realized, I was working with Prof. Tony Moore in his clinics. He says, Bish, you see albinism in Asians and you can miss it. So actually your phenotype is albinism in Asian. So I was really excited. I was thinking like, no, I need to collect these families, and there will be a lot of this, and that will actually make our work easy to find out the candidate gene. Now the problem is, at that point I finished my fellowship and I got onto my consultant job, and as you can imagine, like, when you're in there, the priorities change. So my clinical work was 7 sessions of clinical work, and I couldn't go back to his clinic once I became a consultant there, to the genetics clinic, and look into and collaborate with others to accumulate more of these families. However, the work carried on in Leeds, and Chris and Carmel Toombs, they collaborated with people here, Kumar and the Dutch group, and another group in Italy. And I'm glad to say, like, we found an answer. In terms of albinism in Asian, like, what Tony Moore said to me, that they can have normal skin pigmentation, and you have to compare the child photographs. But we did that, and in this family they didn't have, like, they were normal pigmented. They didn't have any iris transillumination, and the fundus pigmentation was normal. So this is our family from Leeds, Bradford, and this is the Dutch family, which was the 2 Afghani sisters, and they had segregated to the same region. So we narrowed it down further to about 3.1 megabase region, and there were about 37 candidate genes. And then one of Musallam, he's one of the researcher. He was doing his PhD with Chris and Carmel Toombs. So so I provided the clinical data, and then we published this, and then we found this. He went, I think, one by one, and he finally found the SLC 38A8, which Kumar has alluded to. So all this work actually only works, finding a gene, is by having more families, and the way you can do it as clinicians is, and as a scientist, you have to collaborate. And I think the exciting bit about this consortium is that's what we need to do in future. So I won't go to this because Kumar has already talked about, but still there is a lot of things which we haven't understood. So we have found the gene, SLC, but we still don't know very much about this gene. And one of my thing is, we've always thought in albinism, and Jeffrey, who works in Institute of Ophthalmology, he's done a lot of work in optic chiasmal, and the reason why it's so complex, and how melanin is linked to chiasmal misrouting. But what we find now, we have a gene where these patients have optic misrouting, and it's a different pathway. So I came across this editorial after this article was published, and it's quite interesting because the question is, do you have to be an albino to be albino? And it raised further questions in terms of, should the diagnosis be based on pigmentation, because albinism most of the times to clinician is a clinical diagnosis, and then you do the VEP and you confirm it by seeing the decussation. And then what also is there is, like, L-DOPA, which is intermediary, like, before melanin is formed, can cause visual alteration and it can be corrected if you give it to transgenic albino mice. So obviously the further studies are needed on this gene to firmly establish that actually it is, like, and find out answers how this is connected to optic misrouting. So that's where I'll finish my, the first bit of the talk. But what I thought was really exciting is, in terms of the consortium, my clinical interest at this point is, I deal in more fields. I do basically macular degeneration, diabetes, maculopathy, and these are the 2 predominant conditions in the Western world as the leading cause of blindness. So AMD is the leading cause in the elderly population, whereas the diabetes is the leading cause in the working age population. And to find out genes in these 2 diseases, it's very complex, it's multifactorial, and when the AMD genes, the CFH and the ATR, the locus 10, they were found, I think it was 2006, we as clinicians were really excited, and we thought, like, we have these patients and we can do some work and predict who has a high risk, one, and second is, as clinicians, what you find is you keep giving them anti-VEGF injections. So once the anti-VEGF injections came, it was really exciting that there is a treatment going forward. However, what we are finding as clinicians is patients, they are having injections into their 5th year. So there are patients who have had 50 injections. And one of the things, and same thing with diabetes now, we use these anti-VEGF injections in diabetic patients, and they, again, like, no, there is a cohort of patients who don't respond to these anti-VEGF injections so well. So I think the interaction of finding the genetic association to the pharmacotherapeutic response, I think that is very exciting for me. Now I have, like, being the program director for the fellows, I get a lot of fellows internationally who come to Moorfields for their fellowships, and I've done some collaborative work with a group in Adelaide on diabetic genetics of diabetic retinopathy, but I'm really looking forward to collaborating with you all. So thank you for giving me this opportunity. Thank you.